The clinical baseline for initiating intraoperative cell salvage, or ICS, is an anticipated surgical blood loss exceeding 500 milliliters, or 10% of a patient's calculated total blood volume. When blood loss reaches this threshold, clinicians must choose how to replace it. Banked allogeneic donor blood undergoes a physiological degradation over its shelf life, known as the storage lesion. This side-by-side data visualization compares the biochemical profile of fresh salvaged blood against stored donor units. Inside a banked unit, essential compounds like ATP and 2,3-diphosphoglycerate rapidly degrade. Autologous salvaged blood preserves these compounds at physiological levels, ensuring immediate oxygen delivery. Furthermore, in storage, extracellular potassium levels continuously rise, while the pH drops, creating an acidic fluid. Reinfusing the patient's own freshly salvaged blood bypasses these metabolic perturbations entirely, maintaining near-normal potassium and pH. Bypassing the blood bank also removes the immunological tax of a transfusion. Salvaged blood eliminates the risk of transfusion-related immunomodulation and ensures the patient will not develop alloantibodies against foreign antigens. Because it retains its structural deformability, preserves ATP, and neutralizes the risks of immune modulation and hyperkalemia, a salvaged red blood cell provides an immediate microcirculatory advantage over a stored donor cell. This schematic maps the closed-loop extracorporeal system used to recover and process those erythrocytes. The process begins here at the aspiration node within the surgical field, where shed blood is drawn toward the processing unit. This requires a specialized double-lumen suction system. One lumen aspirates the blood, while the second continuously delivers a precisely measured anticoagulant solution directly to the suction tip. This immediate mixing prevents fibrin strands and microclots from forming in the line. Aspiration pressure is strictly limited. The operational vacuum window must remain between -100 and -150 millimeters of mercury. Operators must also avoid skimming, suctioning ambient air over a shallow pool of blood. This introduces extreme turbulence into the line. Exceeding the -150 pressure limit or introducing skimming turbulence subjects the erythrocyte membranes to lethal shear stress, destroying the red cell mass before it even reaches the reservoir. Standard surgical suction exists to clear the operator's visual field by any means necessary. Aspiration in cell salvage is a highly regulated biophysical extraction designed to protect cellular integrity. Once collected, the fluid moves into the mechanical core of the bioreactor for processing. Inside a fixed bowl or variable volume system, blood undergoes high-speed centrifugation. Generating up to 5,600 RPMs, physical force separates constituents by density, packing heavy red blood cells against the peripheral wall. As red cell mass increases, lighter central supernatant, containing surgical debris, plasma, and free hemoglobin, is forced upward and eliminated through the waste port. The remaining red cell concentrate undergoes an automated wash cycle using IV-grade 0.9% sodium chloride. This wash systematically clears remaining hazards, neutralizing activated clotting factors, residual plasma proteins, and the heparin added during aspiration. To meet the strict quality control metrics required by AABB standards, the final processed fluid must achieve a hemocrit recovery level above 50%, alongside a greater than 90% elimination rate for both plasma proteins and heparin. Through specific application of centrifugal physics and saline dilution, the processing unit acts as a mechanical kidney. It turns highly contaminated surgical drainage into a concentrated, purified autologous therapeutic. Achieving that purity requires exact hardware configuration. The disposable bowl kit demands precise routing of the red reinfusion, blue waste, and yellow wash lines, paired with accurate vacuum regulation at the collection reservoir. Before any blood enters the system, the operator must complete the priming protocol. Delivering 5,000 units of heparin per liter, or an equivalent citrate solution, into the reservoir prior to collection prevents immediate catastrophic clotting of the extracorporeal circuit. This decision tree maps absolute and relative contraindications for cell salvage. A perfectly primed machine cannot override strict physiological boundaries. Aspirating topical procoagulant hemostatic agents like gel foam is an absolute contraindication, rapidly triggering fatal clots across the circuit. Homozygous sickle cell disease presents another absolute boundary. The collection reservoir's hypoxic environment triggers sickling in over 50% of salvaged erythrocytes, rendering the product highly dangerous. Other factors, such as overt sepsis or bowel content contamination, are considered relative contraindications. These do not mandate an automatic halt, but require a calculated multidisciplinary risk-benefit evaluation by the surgical and anesthesia teams. Mechanical mastery of the hardware only protects the patient if the operator actively polices the chemical and hematological limits of the surgical field. Historically, clinicians restricted ICS usage during oncological resections due to theoretical fears that reinfusing salvaged blood would result in systemic tumor dissemination. Modern protocols mitigate risk through mandatory leukocyte depletion filters, or LDFs, on the reinfusion line. These specialized filters physically trap large, irregular malignant cells while permitting smaller erythrocytes to flow back to the patient. However, LDFs significantly decrease flow rates and carry a rare risk of inducing severe bradykinin-mediated hypotension. If blood pressure drops rapidly, reinfusion must cease immediately. Obstetrics faced a similar historical prohibition. Clinicians avoided salvage during cesarean sections, fearing that the aspiration of amniotic fluid would cause an amniotic fluid embolism. Clinical consensus now understands amniotic fluid embolism as an anaphylactoid reaction to fetal antigens, not a mechanical obstruction caused by squamous cells. Furthermore, modern centrifuge washing effectively clears amniotic debris from the final product. A secondary concern in obstetrics is rhesus alloimmunization, the risk that an Rh-negative mother will create antibodies when exposed to salvaged Rh-positive fetal erythrocytes. To manage this, protocols require a postoperative Kleihauer-Betke test. This quantifies the exact fetal cell burden in the maternal circulation, dictating the precise dosage of anti-D immunoglobulin required within 72 hours of delivery. Supported by rigorous leukocyte filtration and precise immune profiling, cell salvage is a safe, mandated standard of care for massive hemorrhage in both oncology and obstetrics. In major elective procedures with a moderate, unpredictable risk of severe hemorrhage, clinical teams face a logistical dilemma regarding resource allocation. This cost-benefit efficiency diagram illustrates the economic solution: standby mode. Standby requires minimal setup. The technician connects only the collection reservoir, suction line, and anticoagulant bag. This approach limits the initial financial outlay, costing roughly the equivalent of cross-matching 2 banked allogeneic blood units. The most expensive components of the system, the centrifuge bowl and the wash lines within the processing kit, remain sealed. They are only opened and utilized if the surgical blood loss actually crosses the 500 milliliter threshold. Standby mode equips the surgical team with immediate, highly effective autologous insurance, without burning through expensive processing consumables if the bleeding remains controlled. Reviewing the complete systemic analysis map, every mechanical and physiological step relies on a strict regulatory framework. The definitive governance is established by the AABB 11th edition standards, which mandate rigorous quality control across every phase of perioperative autologous blood collection. For example, AABB Standard 4.2.4 ensures systemic accountability by legally requiring hospitals to define formal operational agreements for all third-party perfusion or cell salvage contractors. Simultaneously, Standard 7.3.4 dictates safety limits on the floor, outlining the investigative criteria teams must satisfy before restarting a collection following any adverse event. The integration of accurate biophysics, precise hardware management, and AABB compliance serves a single clinical objective: protecting the patient's global blood health by prioritizing their own red cell mass over allogeneic exposure. Intraoperative cell salvage operates as a proactive, highly engineered system dedicated to the closed-loop preservation of the patient's biological capital.